Good morning and welcome to Global Neurosciences Institute Grand Rounds. As a reminder, this is a CME granting activity, and in order to grant CME, you have to, in order to get the CME, you have to get it through each system. If you have any questions about that, please contact Nicole Myers at myers@gni.neuro.org. Today, I've had a pleasure to introduce Dr. Ausim Azizi. Dr. Azizi is a well-known and highly respected neurology leader. He is triple board certified neurologist, and he's part of the GNI. He received his MD and PhD degrees from Southwestern Medical School in Dallas, Texas. He then completed his graduate work, internship, and neurology residency at Yale New Haven Hospital. He's board certified in neurology, neuroimaging, and neurocritical care. Dr. Azizi, for a long time, was a chair of Department of Neurology at Temple University. He received many awards while there. He was also invited to become a visiting professor at the Mayo Clinic as well as at the University of Pennsylvania. Dr. Azizi will be talking today about neurological complications in COVID-19. And Dr. Azizi, you can share your screen.
Excellent. Thank you for the opportunity to share some of my understanding about neurologic complications of COVID-19. I want to divide this talk into three sections, discuss the general virology so we all be in the same spring point, and then discuss neurologic manifestations of COVID-19, which includes stroke, encephalopathy, and neuromuscular diseases, and I'll touch on neuromuscular diseases, and talk a little bit about neurophysiology or neuropathophysiology, and briefly discuss some of the treatment options that are available right now and the vaccines. Obviously, the impetus for this talk is that there are up to yesterday 14 million infections in this country and 300,000 or near 300,000 deaths, and it's climbing. What we ought to know is that viruses have coexisted with prokaryotic and eukaryotic cells for millions of years. So it's not something that it just comes up and gets us. They have evolved an intricate molecular dance in cohabitation with prokaryotic and eukaryotic cells. And the way that works is that the viruses live inside the cells, and in a symbiotic way, they're likely enriching the cellular DNA. So a molecular evolution in terms of changing the DNA of animals is probably at least partially virally mediated. And that is part of the environment that allows us to evolve into the environment. At different stages of this evolution, there has been flare-ups of destructive infection of the host population. So the COVID-19 pandemic is likely such a flare-up. The last one was 100 years ago with the flu epidemic of 1919-1920 that killed 1 million people in this country in 1 year. And the current pandemic is brought on by a virus that's coronavirus. It's crown-shaped, and the official name is SARS-CoV-2. That stands for Severe Acute Respiratory Syndrome COVID Coronavirus 2. This is a pictorial representation of SARS-CoV-2. So on the left, and there is an electron micrograph that shows indeed that the virus looks like a crown. These are colorized version of the same picture of the virus. And on the right is a rendering of the artistic rendering of the virus. The crux of the virus, of course, is the nuclear material, which is RNA in this particular virus. And as you can see, it has a shield or a blanket around it. And this blanket is a lipid bilayer borrowed from the previous cell. And there are some studs around this lipid bilayer. And these studs are little proteins that the virus has produced using the cellular machinery of the previous cell and kind of ornamented itself with these studs. But these studs are very functional. They're called spikes, and they're the key to the entry of the cell to the next cell. The coronavirus is similar to other coronaviruses. For example, SARS-CoV-1 that had an epidemic in China in 2001, 2002, Middle Eastern respiratory virus syndrome or respiratory syndrome that came out in 2010s around the Middle East. And now we have coronavirus that is pandemic and global. As I mentioned earlier, it's a large single-stranded RNA. And from a virology perspective, all we need to know is that this makes it more pliable, and there are more places where the virus can become more habitable into the new cells. The virus has an envelope that's acquired from the previous host cell, and these spikes that I talked about are the keys to the viral entry into the next host cell. And the key is really important because this key presents the structural basis for SARS-CoV-2 infection, where it infects only specific cells, not any cell. And that's the basis for its neurologic complications. In terms of epidemiology, SARS-CoV-2 is a zoonotic virus. That means that it's transmitted from animals to humans. It's native to horseshoe bats and mainly in Southeast Asia. And the reason we know that it's native to these bats is because the human coronavirus has about 91% homology with the native horseshoe bat coronavirus. And the intermediate host is thought to be pangolin. And pangolin is sort of an unknown animal, but its meat and its skin is used quite a bit in the Southeast Asia area, and it's the most illegally trafficked animal after humans. Then the reason pangolin is thought to be the intermediate is because its homology of the virus is about 94% with the human clade. So this tells you that these viruses can mutate rapidly. And the reason pangolin is kind of important in Southeast Asia, and this is from Wuhan market, you see that there are pangolins around and the baby pangolins for sale, quite a bit of it. And when you take the skin off, there is a non-protected, non-barrier contact from human hand into the pangolin guts. Then it gets to the humans, and how is it transmitted in humans? If you go from right to left, the virus lives in these particles and it doesn't live on its own. In other words, the virus doesn't float around the air. It lives in these particles, or infective particles of virus live in these bubbles of saliva and other secretions. So as the person who is infected coughs and breathes, there is atomization of the particles that contain the virus, and also droplets fall and contaminates the surfaces in the air. These aerosols that are in the air then gets into the next person. So talking about the masks, the surgical mask that's shown here on the right is good for decreasing the atomization and droplet formation. So it protects other people from you, whereas the N95 masks is good for protecting you from other people. And therefore, each one of those have a little bit different function. So when we go to a COVID-19 patient's room, we need to wear an N95, whereas in general, we just need to wear the regular surgical mask to decrease the transmission. So where and how can we contract COVID-19? It's all about the number of viable viral particles. So it's not virus RNA, it's not virus wall, it's not anything else, but the virus has to be viable and the number has to be high enough to cause an infection. How does that work? Well, inhaling droplets that contain SARS-CoV-2, yes, we do get infected with that. Touching contaminated surfaces, as I showed earlier, the surface can get contaminated if it's wet, then the virus becomes viable, and then inhaling it, yes. Touching dry surfaces, it's less likely. Viral RNA or isolated virus is less likely because these viruses and the RNA is not a viable infective particle. It's less infective because you need that coat and that shield and that key in order to get into the next cell. Eating contaminated food and water, it's less likely. And the reason is that virus doesn't survive in water. It may be sitting in the food, but it goes into the stomach and all that coating is going to go away. So the bottom line is also, in order to attain these numbers that are infective or get high enough number that will cause a clinical infection, you need a larger number of viruses, obviously, and exposure time. Just by sitting and inhaling again and again and again, you get more viruses. So because of that, congregation for long periods of time in a place like a house of worship is worse than, let's say, just going to a grocery store and buying something. In terms of who is a spreader and super spreader by symptoms, people who are positive with COVID-19 or SARS-CoV-2 positive patients, if they have cough and nosocomial infection or symptoms, these are sort of the super spreaders because they spew the virus all over the place. Patients with strictly pneumonia, where they have just dry cough and they have pneumonia, are next. Patients who have only general malaise, they are third. So in terms of the spreading the virus, these are the worst and these are sort of the least. What about asymptomatic patients that are COVID positive? The newest data shows that only about 17% of all SARS-CoV-2 positive patients remain asymptomatic. So if you have a SARS-CoV-2, 80% of people will become symptomatic for sure. And these asymptomatic people, their rate of transmission is only 50% of those who are symptomatic. So people who are asymptomatic in a gradation pattern, they are less likely to transmit the virus. They're not super spreader. But the super spreader are the specifically the COVID positive nosocomial infection patients. So what is the mechanism after the number of virus that I mentioned gets into the system? What is the mechanism of infection? Well, the mechanism of infection is mainly the cells that express angiotensin converting enzyme 2. In other words, SARS-CoV-2 infects only those cells that have the angiotensin converting enzyme. As you know, viruses require a receptor in order to get into the cell. And those receptors are not specifically made for viruses, but they are they kind of hijack the receptors that are already in there. And as it happens, coronavirus or coronavirus 2 takes the angiotensin converting enzyme 2 for their receptor. As you recall, ACE2 works in opposite to ACE. And that is, in other words, ACE2 decreases blood pressure, and it's important in maintaining the circulatory homeostasis. So in humans, ACE2 obviously is expressed in the endothelial and epithelial cells. And there has been multiple studies from 2010 and from the first SARS that came out to determine where these ACE2, which are the key to the entry of the virus into the cells, are expressed. It seems like perhaps 99% of ACE2 is expressed in endothelial and epithelial cells. And that makes sense. Endothelial cells are responsible for their lining of the vessels. They're responsible for increasing and decreasing the blood pressure, and ACE2 decreases the tone and the blood pressure and the blood vessels. ACE2 determines the tropism of SARS-CoV-2. In other words, only those cells that express ACE2 on their surface get infected with SARS-CoV-2, and then the organs that have those cells will get infected, and then only the species that express that particular type of ACE2 can get infected only. Therefore, the tropism of the virus is determined by the presence of ACE2. ACE2 recognizes the viral spike protein, and so I was telling you that spike protein is the key, and here's the lock. So ACE2 is the lock for the viral spike protein. And this ACE2 then enzymatically modified the spike to allow fusion of viral membrane to host cell membrane. And here is a picture of the spike protein. This is cryo-electron microscopy. In other words, the way they can get to this detail of resolution is that you prepare the tissue by fishing the protein out with your antibodies, like hooking a fish, then take that protein and freeze it to almost to the level where the molecular movement stops. And that allows the electron microscope to take a snapshot of the protein. So as you can see, the spike protein looks like an ice cream cone, and it has multiple proteins. The main proteins are S1 on the top, which is kind of the ice cream on the top of the cone, and S2 is what sticks to the viral surface, or that membrane of the virus that's borrowed from the previous host, as I was mentioning earlier. The business end of it is this receptor binding domain, because this serves as a hook. So when the virus gets into the bloodstream or cell, this hook finds the ACE2 and hooks up with it and attaches to the ACE2, and then allows the ACE2 to modify the stalk or the stalk of the spike protein. This is a analytical kind of diagram from physics, not just an artistic rendering. It's called computational molecular physics, and it shows that the spike of the virus, if you look at this, the virus is on top, the host cell is on the bottom, the spike kind of comes in, and the red represents the receptor binding domain, and purple represents ACE2. So that's how they attach to the ACE2. And this attachment here is a real electron microscope transmission showing that the virus is attacking an epithelial cell and the rest of the epithelial cells. And as it gets in, here is a rendering of that particular interaction where the stalk kind of comes in close. ACE2 first attaches, and then as an enzyme, so remember it's angiotensin converting enzyme 2, it starts breaking the proteins that are in the stalk of the spike protein. And as these stalks break down, the viral cell membrane gets closer to the host cell membrane and fuses. The next step after fusion is, if you look to the left here, the virus enters the host cell, and as it enters the host cell, it releases its RNA. Because this is an RNA virus, it starts immediately forming proteins. So it's not a retrovirus that requires it to become a DNA, and then DNA forms the proteins, and that's more with HIV, and that's a slow process. But this virus immediately starts forming proteins and replicating. Here on the right is, again, another scanning electron microscope of a culture. And the epithelial cells are these orange areas that are set here, and the blue little dots or spheres are the virus that keep proliferating and getting out from these epithelial cells. And these are from National Institute of Allergy and Immunology and Infectious Disease. So another concept in terms of a viral infection to the cell is cytolytic and cytopathic. I apologize first if you all obviously know this, but just to be in the same platform, I wanted to kind of review these. A cytolytic infection is when the host cell dies as a result of viral replication. In other words, when the virus gets into the cell, it starts replicating and it kills the cell. Whereas a cytopathic infection is when the host cell survives. and it serves as a viral reservoirs, causing chronic infection. For example, in herpes, we know that dorsal root ganglia and trigeminal ganglia are all reservoirs of the herpes virus. Once in a while, the herpes virus flares up. Whereas there are some other viruses like slow viruses that do a combination of these. Some of the cells are killed and some remain as reservoirs. For example, HIV does that kind of a thing, where it kills the CD4 cells, but it hides in the astrocytes and microglia and macrophages, kind of use those as reservoirs and keeps going. The other concept to remember is that coronavirus does not infect every cell equally. So the point of this slide essentially is this panel on the bottom. So if you look at this panel, there are these viruses that are inside the cell. And as time goes, see that some of the cells are chock full of virus and other cells are kind of spared. And this is kind of important in terms of clinical infection because it tells you as to why some cells in the lung, for example, stay alive and other cells are dead. And so you go that as far as the spreaders or super spreaders, there are events that are super spreaders of the virus. There are some people who have nosocomial infection and they are super spreaders. And then there are cells that are chock full of virus and other cells that are not. So within an individual, you have these cells that are super spreaders and produce tons and tons of viruses. What is the clinical presentation of all of this? So we talked about the structure of the virus, the epidemiology, who gets it and who is at risk, and then the mechanism of how the virus gets into the cells. With the clinical presentation, especially neurologically, is loss of sense of taste and smell. And then the second most common one is nosocomial symptoms, such as sore throat, runny nose, sneezing, and coughing. Lower respiratory symptoms are next. These patients usually have dry cough, low oxygen, and normal CO2. I'm sure you're going to ask, if you have these symptoms, why don't you have these? Or if you have the lower respiratory symptoms, why don't you have upper? And the reason for that is that distribution of ACE2, meaning that coronavirus 2 is capable of infecting both upper respiratory tract and lower respiratory tract, whereas SARS-1 was only lower respiratory tract because of its key and lock system where only specific cells are infected. So because of that, SARS-CoV-2 has the rate of transmissibility of 2 times as much as SARS-CoV-1. And some of these symptoms are kind of telling us that, yeah, that's true, that lower respiratory symptoms can come on their own, and it could be dry cough, low oxygen, and normal carbon dioxide. The next group of symptoms are malaise, fatigue, joint pain, depression, etc. And then COVID-19, pneumonia, vasculitis, coagulopathy, which is fulminant, and these usually end up multi-organ failure and death. And then we're going to talk a little bit about neurologic manifestations, myths and facts. Now, the reason I want to emphasize the myths and facts is because if you just today look at PubMed and just put title COVID-19, in the past 9 months alone, there has been 78,000 articles that's published that has COVID-19 on the surface. Some of those are reprints, some of them are just myths, and some are original and facts. So I tried to kind of go through at least the neurological piece and figure out what's myth and fact, and I want to present that. First of all, stroke. The crux of the question with stroke is SARS-CoV-2 infection an additional risk factor for stroke? Well, how can we approach this? Well, patients with COVID-19 can suffer stroke, we know that, and stroke patients can get SARS-CoV-2. We have seen that in our own emergency room, in our own service a dozen times. Total number of admissions for stroke declined during the first few months of COVID pandemic. This is probably because people were afraid to go to the hospital. Probably there was aggressive triage of these patients. So the total number declined. So that doesn't really mean that the number of strokes declined, but it just means that people didn't go to the hospital for stroke care. And if you look at all the data of COVID positive patients and stroke, and the rate of stroke in COVID-19 patients is only slightly higher than matched groups. And I'm going to show you some of that data. Here's a table, and these are the large studies. These are the number of patients in column 2, and the percent of patients who had stroke. And you see that it varies from 0.9 in an article by Yari et al. About a month ago to an article that came out at the very first in New England Journal by Holmes and al. From Strasbourg, France. That was 4.7%. The truth is that it's probably somewhere around 2.5 to 2.8, and that's only marginally higher than the number of stroke of the same group of patients of this age. These, the outlier are these, the very first paper that showed that stroke is part of COVID-19 and there may be a causative effect was by Oxley et al. That showed that these patients who were pretty young, 33 to 49, they had strokes when they got COVID-19. I think the problem with that is that, again, it's an outlier and it doesn't pertain to the risk of stroke as COVID-19. So what is the possible reason that COVID-19 could cause a stroke? Is that it's viremia first in the vessels, and that viremia then causes inflammation and endothelial infection, and those in turn cause coagulopathy, and coagulopathy and vasculitis can cause thrombosis and embolism. Again, you have to have these first in order to get thrombosis and embolism. So the point here I'm making is that only sick patients with COVID will have stroke, and that then their risk of having a stroke is probably higher because of inflammation and endothelial infection. If you're just COVID positive, you're not going to get stroke. So the risk of getting a stroke due to COVID as a separate etiology is pretty low. And I think that's the fact right now. And the myth is that, oh, you got COVID, you're going to get stroke. And we should be a little bit cautious about interpreting the data. Loss of sense of taste and smell. Over 60% of COVID positive patients exhibit these symptoms. The most consistent and early symptom of COVID-19 infection is loss of taste and smell. At the very beginning, about middle of June, July, when they collated all the symptoms and signs of COVID-19, the most consistent one came loss of sense of taste and smell. And that's because the exposure to the virus is through mouth and nose, and the epithelium of the mouth and nose both contain ACE2. And ACE2 is the key and lock to the coronavirus or ACE2. So the taste bulbs or olfactory sensors are epithelial cells, and they express ACE2. Loss of sense of taste and smell are due to injury to the epithelial cells. They are not because of viral invasion of neural part of the olfactory bulb. In fact, if you dissect the olfactory bulb and look at it under microscope, you see that only epithelial cells are infected, and that's why you lose the sense of taste, and only epithelial cells in the nose that are here are infected, and you lose the sense of smell, but not the nerves or neurons that are in the next level. This particular article that came out in June will take this and they run off with it, saying that the virus that is shown down here gets into the nerves, and the nerve gets into the brain, and that's how brain gets infected. The fact of the matter is that the autopsy series, and I'm going to go over that in just a minute. Well, let me talk a little bit more about the other symptoms, and then I'll come back and talk about the autopsy series as to whether virus is in the brain or not. And that's the major debating question right now. There was another article in a very good journal showing that Parkinson can be caused by COVID-19. And they went through this elaborate fine description of inflammation and inflammation causing Parkinson and so on. The problem with these kind of studies in general, or this kind of explanation, is that it's falling into the rabbit hole, meaning that you pick something, but the platform is not really correct. In other words, the virus does not go into the brain and it doesn't cause Parkinson. And any inflammation can exacerbate symptoms of Parkinson and neurodegenerative diseases. We all know that demented patients, they get a UTI and they decompensate. Parkinson patients become sick with other things and they decompensate. So COVID-19 is no different than any of those other things. So it's not an independent risk factor. It's just a multiplier, like diabetic patients, when the sugar goes high, Parkinson gets worse and memory gets worse. How about encephalopathy? This is kind of a vexing problem because a large number of patients complain of neuropsychiatric issues with COVID-19. These include things like altered mentation, fatigue, depression, joint pain, memory deficits. And these symptoms are reported during the acute phase and the chronic phase, meaning later on during the recovery. And this begs the question, does the virus get into the brain and causes these specifically as an independent factor? And the answer to that in general is probably no. And the likely cause of the neuropsychiatric issues is because of probably more hypoxia, the fact that there is intubation, the fact that there is sedation and long-term, and heart and kidney and liver diseases in a lot of these patients. And then another large thing that's kind of looming in the background and we never tackle is the immune dysregulation. And the immune dysregulation secondary to any infection affects the brain. So as I was mentioning earlier, that when we get a UTI and degenerative diseases or dementia or stroke, the symptoms exacerbate. All of that is because of immune dysregulation. And of itself, the so-called immune dysregulation is not a pathological thing. It is a systemic change in acquired immunity because the immune system got exposed to novel antigens. And as soon as any immune system gets exposed to a novel antigen, they do their job, they react. But the nervous system is in particular vulnerable. And the reason for that is that goes back to the molecular medicine, and that is that the nervous system expresses about 20% more variety of proteins than the rest of the body. So if you bind and grind, take a brain and take another piece of tissue like heart and liver and all that, and you look at the number and variety of proteins, brain is expressing about 20% more proteins. That makes the brain and the nervous system uniquely vulnerable to a normal immune reaction, which we call it immune dysregulation. That probably represents the basis for the so-called neuroimmune issues, where a remote viral infection causes immune-mediated injury to the nervous system. Some of them are acute, like encephalomyelitis and peripheral nerve injury, like Guillain-Barré. Some of them are chronic, like multiple sclerosis and other types of immunologic diseases in the brain. So when we get to COVID, part of that neuropsychiatric manifestations that we see is likely this remote viral infection that's immune-mediated neuroinjury. And the reason the brain is affected by these is because there is a remote immune reaction, and that immune reaction possibly gets to the brain and causes changes. The data for no direct brain invasion is basically the gold standard, the autopsy of COVID-19 patients. There has been about 4 studies. The best one is just about a couple of months ago, came out in Lancet. It's post-mortem analysis of brain of 43 patients who died of COVID-19. And when they looked at the brain of all these 43 brains, there were no evidence of CNS damage that's directly caused by SARS-CoV-2. And this is sort of a direct quote, the second bullet in there, that the virus does not invade and causes damage in the brain. There were inflammatory changes that were in the meninges, vessels, and around the brainstem and the meninges. And these are some pictures of that shows that CD8 cells and CD4 cells infiltrate around the meninges and the perivascular areas. How about neuroimaging? People have shown a bunch of neuroimaging studies showing that, oh, indeed, the virus, in fact. If you look at all these brains of the patients with COVID-19, and these have been very sick people, all of these show that these are pretty non-specific changes. The problem with neuroimaging is that we don't have before and after to compare. These were taken right at the time that the patient had a relatively severe disease with COVID-19. And we know that people who get sick with other things do have changes of this non-specific form, and it's not specific to COVID-19. So neuroimaging can be sort of diagnostic of something going on in the brain, but it doesn't give you the etiology and that this is caused by COVID-19. So when we look at the brain issues in general and nervous system issues, COVID-19 causes lungs and heart problem, kidney and liver, GI. It causes inflammation, can cause vasculitis, as I mentioned earlier, and all of these will cause hypoxia, ischemia, toxin elevation, electrolyte imbalance, cytokine, which then causes encephalopathy, inflammation of the brain and damage to the brain, and possibly stroke, but no direct invasion. So let me just take about 5 minutes and talk about treatments and vaccine. Hydroxychloroquine, zinc, azithromycin have been touted by politically and so on and so forth. And there is remdesivir, that is a treatment. And there is the antibody cocktail and the steroids. All of these our president got treated with. And then there is vaccines that are mRNA vaccines that are now ready for use and protein vaccines that are under development. First, about hydroxychloroquine. There are a number of observation reports, in fact, 148 of them. Some of them show that it's effective, some of them show that it's ineffective. So none of these are randomized controlled trials. Finally, November 24, just a couple of weeks ago, article from New England Journal came out showing a randomized controlled trial and showed that therapy with hydroxychloroquine did not prevent SARS-CoV-2 infection or symptomatic COVID-19 in healthy persons exposed to PCR positive case patients. Not only that it doesn't help as a prophylactic, but even if you're exposed to patients, it doesn't do anything. So that hopefully should put the nail in the coffin of hydroxychloroquine. Second is convalescent plasma and monoclonal antibodies. And this is the virus that's a rendering of this. I thought this was a cute picture, so I would show it. So antibodies are attacking this virus, and it looks so great in a picture. So they haven't done the full study with monoclonal antibodies, but the convalescent plasma, that's the basis for monoclonal antibodies, did not show any improvement. Remdesivir, on the other hand, is a blocker of, it inhibits the viral replication by viral RNA-dependent RNA polymerase. So in other words, once the virus gets into the cell, remdesivir blocks its replication, so the virus doesn't cause the explosion of the cell. It is superior to placebo in patients who are hospitalized, and it decreases only the hospitalization from 15 days to 10 days. It's about 30% effective, which is the threshold that FDA allows the medication to be approved. So the article is a New England Journal article showing that it is effective only to the point that it decreases the hospitalization. Corticosteroids, they are helpful in severe cases. In other words, if someone has severe pulmonary or COVID pneumonia, and the cytokines are, if you look at the lower panel here, this pink shows cytokines that cause destruction of the pulmonary alveoli, then steroids can be helpful there. For patients who have mild disease and they don't have severe pulmonary problem or respiratory problem, steroids could have the opposite effect in causing infiltration and proliferation of the virus that then cause destruction of the lung. So steroids have a two-way. If you have severe disease, steroids are helpful. If you have mild disease, steroids are not helpful. Should not be taken as a prophylaxis. How about the vaccines? And the vaccines that are now being approved are RNA viruses. So I remember I showed you the structure of the virus. That's a large 28,000 bases of RNA. So 1273 is this piece of RNA that produces the spike. And if you take this 1273 and kind of package it in a way in either in liposomes or by itself, that is basically the vaccine. And the reason it has to be kept at very low temperatures is because this thing can curl and turn around and break in higher temperatures and can cause problems, and vaccine can be ineffective. So that's why it has to be kept in cold. As soon as you inject these vaccines into the muscle, they get into the muscle cells and they start translating proteins after entering into the live cells. And those proteins that are translated are foreign antigens. In other words, they are viral proteins, specifically the spike protein here. And this spike protein can activate an immune response in the person that forms these proteins. And by producing the immune response, those people hopefully become immune. And a booster shot is needed later to increase or expand the clone that was producing the antibodies. So it's a reaction against the spike, and the booster shot promotes clonal expansion of the sensitized B cells. And if you want more reading, I wrote this paper that published just a little while ago, and you can take a look at that. I want to stop here so there will be some opportunity for questions, and thank you for listening. Dr. Glebas.
Dr. Azizi, thank you very much. And when I say thank you for these great grand rounds, I'm definitely echoing not only my own sentiment, but I was getting messages through the presentation. It is how refreshing it is to actually listen to something that is so purely scientifically based rather than anecdotal evidence or anything like that. So again, thank you very much for grand rounds. We do have several questions for you. There are several questions came in, and there are a couple of questions that are more specific to the disease, and then there is one general question, which I'm going to leave it to the end. So the question came in, so we know that SARS-CoV-2 causes like vasculitic changes, thrombotic changes, and that is possibly a mechanism of the ischemic stroke. Is there any evidence of the COVID virus association with the hemorrhagic intracranial events?
I don't know of any of those. Again, those patients who do have a couple of comments on that is that patients who have vasculitis can have friable vessels. And if they have other factors, there's conceivably could have hemorrhagic stroke. But there's no clear data on that. There has been a sporadic case reports, but no specific study. In other words, I don't think COVID-19 by itself is a risk factor for hemorrhagic stroke. It can be a vasculitis type of stroke that's a patchy type of stroke in there.
Another question, Kevin, is there any association or data between COVID-19 and acute hemorrhagic necrotizing encephalopathy?
No, there's no, we do not have any reports. Acute necrotizing encephalopathy, as everybody knows, just to kind of refresh your memory, is a severe immune reaction to some of the vaccines, for example, the viruses, for example, not smallpox, rubella escapes my mind. And those viruses can get into the brain, sometimes can cause an acute necrotizing encephalitis that is associated with the virus. And the way it works is, from the other viruses that we know, is that some virus gets into the brain, some virus activates the immune system, and the immune system is what precipitates the destruction and frying the brain, so to speak, and causing the brain to become necrotic by the immune attack. And there's no clear report that that COVID-19 is going to cause this or has caused this. In general, because coronaviruses are not the same as the specific viruses that attack the nervous system and has a receptor in the nervous system. For example, rabies has receptors and herpes has receptors in the nervous system. And other encephalitides like equine encephalitis, Japanese equine encephalitis, have receptors in the system. So they can cause a direct invasion and necrotizing encephalitis, whereas coronaviruses in general do not cause that kind of a severe immune or fulminant immune reaction. So as a consequence, I don't think it's likely. First of all, there's no report that that happens. But I'm thinking also that it's unlikely that this will be causing, that this virus and specifically will cause this. Because as I said, it's similar to MERS and SARS-CoV-1. And we have a huge literature on those two, and we know that it doesn't really happen.
We have also some questions about the treatment and vaccination. So when it comes to treatment, is there an antibody therapy specifically for mild diseases in non-hospitalized patients? And how does that differ from the Regeneron product?
They are not. I don't know of them if there is any, but my sense is that that wouldn't work, because this is harking back to a very old type of treatment. We called it serum treatment in the early 1900s. When people got infected, you take the serum from someone who has already been infected and infuse it to the other person to see if this works. And sometimes it worked and sometimes it didn't. And other times it caused another reaction in the patient. And the 5,000 patients with recovered serum from patients who were COVID positive recovered. They took patients, and this I think was done at Columbia. These patients, there was no change really from in terms of recovery and other things for these patients. So my sense is that if the serum therapy, that's kind of a mixed bag, didn't work, the specific antibodies may be a little bit more honed in against the virus, but they probably will not work.
There is a vaccination question. Is there, what is your opinion? Is there a role for vaccination in patients who have already been infected?
Yes, and the reason for that is as follows, that I think that this virus, as I showed you some of the evidence, that it mutates relatively rapidly. In fact, from the genetic signature, we can know now that there is 2 or 3 different clades of virus in this country. There's a West Coast clade, and then there's East Coast clade, and then there's a middle clade. And then the other frightening thing was that whole fiasco with the mink farm in Denmark. And the way that worked is that the minks got COVID-19, the people got COVID-19, some of the workers in there. And it turns out that that clade was so different in terms of its spike protein from everybody else's that it frightened everybody that this is a completely new virus that's going to now go through like a fire. So they killed 7 million or 17 million minks in Denmark. And so the question is, well, how fast this virus is going to mutate. Because when it was in bats, it has a different form, and in pangolin, it has a different form, and in humans, it has a different form, and now we already have 2 or 3 different clades of it. So vaccination is not going to be a permanent solution. In other words, once you get vaccinated like smallpox, you probably will have to vaccinate every year or every 2 years. The longest study of vaccination in people who have had COVID, or organized the study of it, just published yesterday in New England Journal. It's 90 days. And 90 days, no, I'm sorry, it's 120 days that people who were vaccinated still produced antibodies after the 1273 vaccine that I was just mentioning. And they are continuing to observe that cohort of patients to see how long they're going to have antibodies. And then the other things are that there are sporadic reports of patients getting again and again COVID, and that tells us that it's probably something that we have to be careful about and do to the vaccination.
And I have one more, it's a more general question. Could you comment on the importance of using actually tested data to make statements in healthcare? Because there are so many myths that are coming from medical community, and then it's easily spread by the media. So.
Testing and spread?
No, in the sense that there is that the data that is being spread by the media that frequently comes from the medical community frequently is not really tested or confirmed, and there are these anecdotal evidence flying around, and people are.
So that's why I sort of mentioned at the very beginnings there has been an infodemics. It's kind of sad because every single lab turned around and geared up to do COVID study. If they were doing protein chemistry, if they were doing DNA research, if they were doing RNA research, everybody is now concentrated on RNA. Part of it is the money. So everybody kind of goes and follows the money. So if there is funding for this to fund your research, then you will go towards that and do that. So the second part of it is that how can you, in fact, I feel confident after writing that paper and giving this grant round that I have gone through all of the high points of what is COVID-19 all about. And if I could summarize 70 or 80,000 articles in this 1 hour, you know that most of that is sort of either reprints. In other words, they take one thing and they run with it. And then the media picks it and the media hypes it because that's their job. And unfortunately, the scientific community doesn't put a stop to that because everybody wants their 15 minutes in the sun. So they go on the television and say certain things that are really untrue. And all of that feeds into that, but that's because we are living in that world, and that's the Twitter and Facebook thing. I'm going to give you one example. The concept of cytokine storm, there is this whole name about cytokine storm. So I tried looking that up to see, well, what is this all about really and scientifically? Is there something? Well, there are 2 reports of 3 patients, Chinese, that at the very beginning, what they did, they measured IL-6 and IL-12 and a couple of other things. And then they said, well, some of these inflammatory markers go up in these patients, and that may contribute to some of the disease, which is true, all of that. And then suddenly there was a commentary in Lancet saying, oh, there's cytokine storm in that. Then the next thing I see, these come sort of one after another, as a very reputable lab in University of Pennsylvania. There is this whole review paper on cytokine storm and how COVID could cause. And the basis of it is that there's really no evidence of major cytokine storm. Yeah, there is. It's a viral infection. It causes inflammation. But there's no specific cytokine storm that can be attributed to COVID-19 as opposed to any other virus. And these people write 8 million things, and that becomes a thing now. A cytokine storm is a thing, and that, oh, this happens in there, we must take care of this and give this and that. And that's the methodology, how we can start from something really false, and then everybody, even very learned people, fall into the rabbit hole with that.
So I do have one more question, but before I ask, can I ask you to display your article again? Because there are some people are asking just, again, for the name.
You can just Google it. COVID-19 Azizi, that's it. Let me see if I could. I'm not very good at this, so what do I do here?
Just share the screen again and share that article.
Oh, I see. Oops.
And you can just share the picture of it in the presentation. So
I know, but the thing is that now I lost everything.
That's okay. So just Google it, and COVID-19 Ausim Azizi.
Yeah.
And it's I believe it was in Journal of Neurovirology. Yes.
Yes, Journal of Neurovirology. But you can Google it. It comes up at top.
Okay. So then there is a question about the testing. What's your opinion? Are there some of the which testings are more reliable? And how do they compare to standard of testing? All the rapid testings.
So the rapid test is both checking for the viral protein and checking for the viral RNA. Both of them just detect not necessarily viable viral particles, but they detect the presence of either viral protein or viral RNA. For the most part, those are pretty accurate. And if you have the viral RNA, well, you may have been infected at some point, because compared to the normals, you shouldn't have those. And there are lots of people who don't have the viral RNA. That is good, but the testing is not going to cure people. That's the article. Do you see that? No.
No, we don't see it, but actually one of our viewers found it, and it's called Neurological Injuries in COVID-19 Patients, Direct Viral Invasion or Bystander Injury After Infection of Epithelial/Endothelial Cells.
Okay.
And your first source.
Back to the testing. Testing is not a medical thing. It just tells you, well, you have been exposed to this virus or not. And I was recounting all those symptoms that a lot of people are asymptomatic. But 80% of people, if you are not just exposed, but you are infected with the virus, 80% of people will show some signs and symptoms. And so there is a large margin of error in there that when you test positive, do you actually have infection? And infection means that you have clinical symptoms and you're spreading the infection to others. And I tried as much as I could in one of those slides to show that this may be the case or it may not be the case. So testing is important in terms of guiding the public health, but I think the best thing that's happening right now is what's happening in California, where they are looking at the number of ICU beds. And the testing is important to allocate resources, not for anything else. And also testing is important for your general social interactions.
Perfect. Thank you very much. Again, thank you very much. There was such a great talk, and I think everybody, whoever listened, everybody benefited from it.
Thank you.
For all the people who joined in, please join us again in 2 weeks, and the grand rounds will be given by Dr. Adam Sarkar. Have a good day, everybody.